introduce Dr. Mani, who is a graduate of the Christian Medical College in Vellore, India, and he trained in plastic surgery at the University of Kansas. From 1974 to 1995, Dr. Mani served as the medical director of the Jean and Barbara Burnett Burn Center at the University of Kansas Medical Center, and as a consultant to the burn care programs of numerous developing nations. Dr. Mani will address partnering with internationals to serve the forgotten. Dr. Mani?
As we get started, I want to introduce two people who are with me because I firmly believe that burn care is a team effort. And with me is Maria Pina. She is an RN and she is the nurse manager for the burn center at KU Medical Center. And Trina Schultz, she's an occupational therapist who has worked in the burn unit. So we three of us are going to present our experiences on international medicine. Now, the Greater Kansas City has several organizations that have done wonderful work in international medicine. The fact that you all are here interested in Inmed and international medicine speaks for itself. We all recognize Heart to Heart and Medical Missions Foundations and many others who have done work. All of them provide vital services. But our team went about it in a different fashion. So what we want to present, what we did. It is not right or wrong. You're right, we're right, none of that. It's our experience and what we learned from working in an international scene. So when Nicholas asked me to talk on this partnering with internationals and talking about serving the forgotten, we started asking some questions. We're not going to give you the answers for these questions. Those are your own answers that you have to develop. Who are the forgotten, the marginalized, and the oppressed? Who calls them marginalized? Are they in some remote, exotic locations, or are they in our backyards? Are they different from us in language, in culture, religion, traditions, and expectations? Now, what gives us, the three of us, the credibility to stand here and say these things to you? I straddled two cultures. I was born in India, grew up in India, and so I can blend in the Indian scene and the United States scene without any problem. I can speak more than one language, and even my accent changes from an American accent to a British accent to an Indian accent where I am. Maria grew up in Mexico, and she thinks in Spanish. She's comfortable in both cultures. Trina has a background from Germany. So three of us are here who can straddle two cultures, and we can blend in both cultures. So when we are looking at the forgotten, are we looking only at the economic status when we clump them as the forgotten, the oppressed, and the marginalized? Do we judge the forgotten by what we have and what they don't have? Are we looking at the whole issue when we are looking at this perspective of international healthcare? Now, I want to ask you this question, and I've been asked this question. Can you walk into my home and tell me how to live, how to solve my problems, how to raise my children, how to eat, what to eat, how to dress, and what to believe, however poor or forgotten I may be? Why should I, as the forgotten, trust your motives? Why should the forgotten trust my motives? So words have been interpreted by the hearers in many ways. And if you look at the last best word in dealing with other countries, other people, other cultures, I think the word is respect. if we can respect the people that we are dealing with, then we will get respect in return. So what does the poor and the forgotten of the world learn about us, our faith, our motives, by watching us and our actions? Sam Harris in his book says, you need not be a faith-based organization to build houses, feed the hungry, and heal the sick. What can we do? What can you do that the secular world cannot do? Mahatma Gandhi, in one of his books, has written this. He talks about social sins, commerce without morality, politics without principles, wealth without work, pleasure without conscience, education without character, science without humanity, worship without sacrifice. Now, some of you may want to write this down, but I tell you that Micah and Skylar have these. We have given it to them. It's in their website, and you can download the PowerPoint presentation from there. Now, what is the perception of the forgotten and the poor from their side, from their aspect? We go there, and they're looking at us. What is your motive? You are in a country where, and how many of you have been to Cambodia? Yeah, I was in Cambodia, and I was surprised to hear about them talking about the American war. And it took me a little while to say, oh, the same war we refer to as the Vietnam War. So what is their perception? A nation who bombed my village, killing my family and claiming collateral damage? The first world living in luxury in a society that subscribes to prosperity theology and praying, give us this day our daily bread, when the pantry is filled with food. Now, this child has a right to pray, give us this day our daily bread. This picture was taken by Kevin Carter, the Pulitzer Prize-winning photographer, during a famine in Somalia. The picture is worth 1,000,000 words. Now, we can serve the forgotten and partner with the internationals in several situations. We can partner with them in times of disaster, after a tsunami, after an earthquake, after a tornado, after some natural disaster. Sure, that's the time we can partner with them. We can partner with them in times of war, when there is so much of damage done to people and everything around them. Yes, we can. We can partner with them in times of peace and as part of a long-term strategy. What we are going to present to you today is our experience when we partnered with the internationals in times of peace and as a long-term strategy. But the bottom line, the question that I would like to leave with you, what is your motive for doing this? So what gives us the credibility to stand before you and say these things? What has been our experience? Our team has set up programs and dialogue with people of Kansas. I specifically put that because in 1974, when I came here, I was an unknown. A brown-skinned guy coming from a different country trying to teach people in Kansas how to do burn care. And I was looking at it with a little bit of jaundiced eye. Now, I felt that in the first 10 years of my life here. Then we dialogued with people of India, my hometown, my home country, and Malaysia, Kyrgyzstan, and Australia. This is in the field of burn care, burn management, and wound management. And each of them taught us something different. Our team set up and organized a system of burn management for the state of Kansas. In 1969, when I was doing my residency, we did not have an ambulance service. We did not have a transport system. We did not have a triage system. We did not have 911. All of them came in the early 70s, and I was there when all of that started. It was a fabulous time. I was a stranger and unknown at that time. The core foundation of what we set up in the 70s still stand. The superstructure and the buildings have changed, but the core knowledge and the core vision has remained. Then we took the idea to Malaysia from 1986 to 96, Kyrgyzstan from 96 to 99, Australia from 95 to 98, and in India from 1990 to the present time. It was truly a learning experience for us. Each region needed a totally different approach. The core knowledge remained unchanged. Our vision remained unchanged. The way we approached the local partners were different. The first international program that I did was in Malaysia. How many of you have been to Malaysia? Know of Malaysia? Yes, there's some people here who've been to Malaysia. Malaysia is in Southeast Asia, just north of Singapore, and it's in two different segments: Peninsular Malaysia, which is marked in red, and East Malaysia, which is marked in green-yellow. I had the unique opportunity to get involved in Malaysia. The chief of plastic surgery in Kuala Lumpur, the capital city of Malaysia, was a former student of mine. I visited him in 1984, and he took me on rounds to see the patients, and he introduced me to this girl. And there was a small party going on around her bed. They were celebrating, they had a cake and all kinds of goodies there. It was her 365th day in the hospital. So I also participated in the celebration, and when we came out, I cornered my former student and said, I thought I taught you better. Why is this patient in the hospital for 1 year? This patient should have gone home 11 months and 15 days ago. What is the celebration all about? And he said, sir, this is our system. I said, change the system. And he said, okay, if you help me, we'll change the system. So we set about changing the system. So I spent about a year, 6 months sabbatical and 6 months here and there without pay. We made an assessment for the entire healthcare system for the country of Malaysia. We studied the health hierarchy, the health directorate, hospital facilities. I have visited every hospital in the country of Malaysia. So it was a fascinating experience. We looked at the equipment, we looked at the supplies, we looked at faculty, staff, training, educational resources, caseload, cost of care, and cost of setting up a program for that country. It was a fascinating time for me. What we found was Malaysia is ethnically made up of 51–52% Muslim, about 30% Chinese, about 10% Indian, about 1 or 2% Proto-Malayan tribes, and expatriate. So we had to look at each one of them and bring them in the team. This picture is interesting because all of them that you see, all the ladies there, are Muslim. The one on your left lower corner is probably the most orthodox of them all, because she has the outfit that covers only the face, covers everything else. Hamida Mustafa, she's been to Kansas City, and I got an email from her last week, so I still keep in touch with her 25, 30 years later. The one to her side is the least orthodox. She is also a Muslim, but wears regular Western type clothing. And the 4 ladies in the back shows different stages of orthodoxy in their religious beliefs. So we had to accommodate all of their belief system in setting up the program. And then there are Chinese. Now the Chinese people have a different dietary habits, dietary system. Their religion is different. We had to accommodate that. And then there was the Indian population. We had to accommodate all of them. Some of the hospitals were tiny, and these were primary care hospitals where only the minor, minimal injuries would be treated, and some of them were world-class hospitals with everything you can think of. You want an MRI, you want a CT, you want all of them are available there. Heart surgery is done in Kuala Lumpur, so we had to accommodate for all of them. So I spent 6 months of my sabbatical leave from the university. We submitted a budget for $40,000 in 1985–86, probably worth $1 million today. And we decided at that time that no funds whatsoever would be taken from the United States to Malaysia. All of it would be raised locally. SO Malaysia, one of the oil companies, gave us a grant of $30,000. The Malaysian government gave the rest. So we had our budget without any problem. We trained the first batch of medical, nursing, and allied health professionals in 1986. In our assessment of the patients throughout the country, we found that majority of the major injuries succumb before they even get to the hospital. So it is the minor and the moderate injuries that survived, and they survived in spite of medical care. And what happened was they would be left with deformities such as these. We will go into more details of this tomorrow when we make our presentation on burn care management. But for those who will not be coming here tomorrow to hear us speak, I want you to put your arm by the side of your body and put your one finger to where the elbow is. Now raise your arm all the way up to the top. Now this is the amount of skin that we will need to reconstruct that individual. It could have been prevented very simply if somebody had worked on a splint when the injury was going on. So that was our goal. Our goal was to get involved with it at that time. Trina, you want to say something?
Dr. Mani spoke about the skin needs to work with this gentleman. He also has atrophy of the muscles. He also is going to have tightening of the muscles. So just surgically addressing this injury is going to be a very short-term part of the entire rehabilitation process. And unfortunately, this would be a very long case.
We wrote a book at that time because somebody said, they want to go home with some information in their hands that they can refer to. So we wrote a book, and I have the very last copy that was printed in 1986. But this has had several revisions, and today this book is in Vietnam, in China, in Kyrgyzstan, and in Australia. A copy of this book is available. I've given it to Micah, so if you want to download it, it is yours to download, no charge. So over the 10 years, we trained trainers, we trained people to train others. We trained medical, nursing, medical assistants, physical and occupational therapists, firefighters, ambulance drivers, and in 1996, the local leaders took over the program and we were officially fired. That was one of the greatest moments of my life when the chief of plastic surgery in Kuala Lumpur in Malaysia said, "Sir, you don't have to come back anymore, we can handle it ourselves." That was a great moment for me, for us. So what did we achieve in Malaysia? Today we have established 8 centers for burn care. We have trained 400 plus professionals using existing facilities and existing equipment, developed teams for each center. The locals are carrying on the program, and in the process we made a lot of friends. So we get emails and letters from people in Malaysia on a regular basis, and I make it a point to go there at least once a year to visit my friends. Now, interestingly, about 10 years later, we had a call from Malaysia saying, "Can you train some of our people in microsurgery and replantation?" We said yes. So they sent 4 people from Malaysia to Kansas University, and we trained them in microsurgery, and now they're doing replants on their own. They don't need our help at all. Anyway, I was going to show you a map of Kyrgyzstan. Kyrgyzstan is very much in the news today because there is a civil war going on there. The president has been chased out and there's fighting going on, and it's a very sad situation. America has one of its air bases at the Manas airport. So Kyrgyzstan is very much in the news today. We were asked to go there and assess a need for burn center. And we met very many obstacles. In Malaysia, we were invited by the locals. In Kyrgyzstan, we were thrust on them by the International Health Alliance. AIHA, part of the State Department, had a program in Kyrgyzstan, and they wanted us to go and do that. So we were sent by AIHA and not the Kyrgyz people. And the problems that we encountered were, number one, they spoke Russian and we spoke American. So we had to have translators every step of the way. Fortunately, the person who was our coordinator at Kansas University Medical Center spoke fluent Russian, so Mrs. Louise Redford was a blessing in the program that we did. The locals did not trust us or our motives. They asked us, why are you here? They were asking them that question. Trina, you have a story about that.
They took us to the Lenin Museum, correct?
Yeah, let me.
The Lenin Museum one day in Bishkek, Kyrgyzstan, and they were very proud of this museum, and it's really quite fascinating, the artifacts and the memorabilia they have of Lenin that is dispersed throughout their countries and their museums. But as we walked into one room, they were very proud of this mural on the ceiling, and as I looked up, I saw a lot of flags, and then I saw a warhead, and I saw a skeleton on that warhead, and the skeleton had an American flag. That was their perception of us. And I remembered I looked up at it, and my interpreter said, "Oh, we don't think that way anymore." And in the back of my mind, I wanted to say, then let's paint it. But out of respect, I stepped back and I said, I understand. I hope that we can show you a different America.
The Russian system was quite rigid. Anytime we suggested a change or the way we did things, the answer would be, but the scientists from Moscow told us differently. So we will believe what the scientists in Moscow said. So this went on and on and on. And the Russian system was very rigid. The country was economically poor, and the healthcare system left a lot to be desired. The person in the front of that screen is a Russian surgeon, Mikhail Kurbanovsky. He was my main obstacle. Everything I said, he would oppose. Everything I suggested, he would say, no, we have done it before. This is how we do surgery. This is how we do it. So we watched him for a couple of days. But I'll tell you the story. Towards the end, we made him a convert. We made him a convert to our way of thinking. And after that, life became very, very easy. This is the great picture. Maria, you want to say something?
Yes, in burn care, in burn management, infection control is a big issue. So when Dr. Mani spoke about the importance of teamwork. And so we had to immediately, we noticed that we needed to work on the concept of infection prevention and control. And we saw that they didn't use gloves, and we asked, well, where are your gloves? They really didn't have any gloves. And so we had to work on that. And also you notice on the draining dry, now it's dry, the drainage, the dressings look a little dry and adherent, but you notice it's sitting right on the lab coat. And you notice that they are handling that without any wound without any gloves. So, and they do that with a lot of patients over and over. So that was a big issue. The other thing is that you'll notice that the hand is wrapped in all together in one bandage. So really, if you have your fingers are burned, they're healing in the web. So we had to do a lot of work with the entire team to prevent scarring and adhesion of those areas. So a lot of concepts that we needed to emphasize.
Another major obstacle we came across was hospitality. In the Russian, Central Asian thing, hospitality was the big thing. So you'd be surprised. We go for lunch in the hospital cafeteria, and there's vodka and champagne and things left out there. And I don't know if you realize, in the Russian concept, for each dinner, they will count 1 liter of vodka per person. That was enough to anesthetize me. And at lunchtime, they would say, all right, we want to propose a toast. So they pour a jigger of vodka, and you're supposed to drink it neat. How do you go to work after about 5 or 6 of those? This was our problem. We had very limited time to make the assessment, make our recommendation to AIHA, but they kept us kind of drunk most of the time. And we would be invited for dinner every night. And this was some of the spread that we would come across. We knew they are a poor country. They have spent their money to feed us. We are not interested in food. We are interested in trying to change the system. So this became a real tussle for us. So finally, to break the stalemate, through our coordinator, interpreter, we appealed to the Prime Minister. The Prime Minister stepped in and said, all right, you guys back off, listen to what they have to say. So that was a breakthrough. Then we asked them to give us 2 patients. Give us 2 of your patients. We'll treat them our way. And then you can make an assessment whether what we are doing is right or wrong. So they gave us 2 patients. And one was this gentleman. He'd been in the hospital for about 2 to 3 months. He still had open wounds on his legs. And it was draining and dripping. And he was in misery. So we went to the market. We spent our own money, got some bandages and some gauze and some ointments, and we started washing him and cleansing him and bandaging him. And in about 3 days' time, these guys were up and walking, and they were up and ready to go home. Wounds had already healed, almost healed in that 3 days' time. That broke the ice. Once they realized that we had something concrete, positive to show them, then we could do nothing wrong after that. So once we gained their trust, things became very, very easy. Trina?
The young lady is dipping plaster Paris strips because we're going to make a splint. Now, what Dr. Mani has talked very briefly about is when we were in Malaysia, they were a fairly forward country, and they were starting to have things such as plastics for splinting and compression for some of our burn scars. In Kyrgyzstan, we had nothing, and I was actually forbidden to even bring my plastics over. I was to treat using whatever I could find there. So we were using plaster Paris. Now, when we use plaster Paris here, I mean, we use a roll, and you keep going until you get it where you want it. There we would use, for a simple hand splint or a wrist splint, I would try to use 4 links. That's it. If I needed it to be stronger, we found straws, pieces of wood, anything. But we're starting to teach them how to do some simple splinting, simple immobilization, so that we can maintain some function.
Priya? About the bathing system?
Can I see the other one? And the other one is Mrs. Louise Refer. She's our translator. She's also an RN, and that was with us. You can see Trina on the other side. Here in our burn center, we're very fortunate. We have just all our equipment at our hand. We have the way we treat our wounds is we wet the dressings and moisten them and remove them. We have hydraulic shower systems, water piped in where you can drip it and you can so that you can wet the dressings and remove them. There we had to improvise. Again, we didn't have anything. We had to go to the market and that was a table that we had available, and that we figured that we could make a shower cart out of it. And we have a plastic that we got at the market, had to transport the patient and position him there. Now we had to also get water. We didn't have any running water or drain system, so we had to actually get buckets, water, and then warm it up in there so that we could moisten the dressings and actually remove the drainage and clean them. So it was very time consuming and very hard to do, but it did make a difference, and they were able to see the importance of cleanliness and infection prevention, and they were dressing just the way that they did their dressings. Actually, they had it the way they mentioned that they left them open, and they really didn't wash the wounds. They just let them crust over. So this was a big change for them. So it was pretty scary for them, and so being able to see that change was very important. But improvising, a lot of work.
The culture was absolutely fascinating. If you look at that picture, we all had to wear that hat. Looks like a chef's hat. That was absolutely necessary. You couldn't go into the hospital without wearing that chef's hat. But mask, gloves, hand washing were all really not, so we really had to, yeah, we wore the hat just to keep peace. We didn't want to create a fuss, but then started gradually introducing the concept of a mask and gloves and things of that nature. Some of the patients that we saw, this child survived but required very many surgeries, and I did surgery on this kid while we were out there, and it was really tough to do surgery without a tube in the throat, and it was really, really difficult, but you got to do what you have to do. So third area that I would like to mention briefly is India. American Burn Association is partnering with health volunteers overseas to provide ongoing education using my alma mater as the base. 3 sessions have been done so far, and the next session, which hopefully will be in January, will be using telemedicine to beam to 10 different sites in India to train in wound management and burn management. I've already done the lecture series for them in a PowerPoint presentation. So here we have Malaysia, a very progressive country, Kyrgyzstan, a very underdeveloped country, India, which is technologically very, very advanced. We had to change our thinking, our way of approaching the partners to suit their needs, their perceptions, what they needed. We were not going there to tell them how we do it and this is how you do it. So if you hope to make a difference, you need to understand the language, the culture, the tradition, religion, and why they do what they do. Imperialism has left its effect, and these are so points. Respect is the key to open doors. When I was growing up as a medical student in Christian Medical College in South India, as we walked in through the main hospital entryway, college entryway, this poem was framed and it was hanging on the wall, and we read it every day. And even today, I read it every day. It says, go to the people, live among them, learn from them, love them. Start with what they know, build on what they have, but of the best leaders, when their task is accomplished, the people will remark, we've done it ourselves. Now we'll open this up for conversation. We have a few minutes. Maria, Trina, and I will be happy to have a conversation if you have questions.
Go ahead.
More of a nuts and bolts. How do you within yourself, when you see, like in the Kyrgyzstan example, a better way to do things, but realize that they've got their ways that maybe aren't all bad? How do you find yourself not getting that superiority?
That's a good question. The question is, how do you stop feeling superior when you see an inferior culture? If you respect the individual, then the superiority, inferiority goes away. I've always made this comment. If you meet a person from India and the person greets you with the hands folded in front of their face and the head bowed down, and they use the word namaste, which means I see the God who lives in you and I respect you for that. So if you have that respect, doesn't matter what their system is, what their culture is, what their way of doing it is. You bring it very, very slowly. You don't go there and saying, you dummy, is this how you do this? They're going to turn you off completely. They will very politely listen to you. The moment you go away, they will stop. So my experience, Malaysia, 85 to 95, 96, they're managing. I go there, they're doing very well. They don't need us anymore. Kyrgyzstan, 10 years ago, they're doing well. I hear them, they write to me, they're doing well. They don't need me anymore. India, they're doing. So my feeling is that I have empowered them to do their own way. They're not doing what I told them to do. Not word for word, no. They have modified it. Glory be. So I'm happy that they are taking their own, tearing it apart, putting it back together, but patients are getting care. That's what matters to me, not whether they follow my system or not.
Any other questions for Dr. Mani? Yes.
Could you go back to the last slide with that poem?
If I can make this go back. Oh, there you are.
Thank you.
Now this, like I said, all of this is with Micah and Skylar. We handed over all of it to them. There are some references that we are referred to. The entire PowerPoint, our outline, everything is available. So all you have to do is download. We decided this time that we won't be cutting down trees and making hard copy. So it's all digital copy and it's available for you.
Yes, question?
You see much tetanus with these burns?
Yes. The question is tetanus. Yes. These are all things that will come in the book that we gave them. All of this is there, step by step, one by one, what you need to do. Tetanus is part of that system. But that comes later. Once they accept your concept, accept what you're trying to tell them, and they evolve their own, they will call back and say, what do I do next? Have you given tetanus? Oh, we forgot. Okay, now you need to add tetanus to your protocol. So they develop their own protocol. We are only the people who planted the seed. Yes. And we will be addressing all those tomorrow when we are talking about burn care tomorrow. We have 2 sessions tomorrow on burn care. We'll address those. But this time we are talking about how do we get to the people who differ from us in looks, appearance, thinking, religion, tradition, food. How do we get through to them? That's the bottom line.
Thank you, Doctor. Thank you.